Welcome to Serious Business on NDTV. 30 minutes of hard business news. One topic, one speaker, and a conversation that's relevant to you. I'm Manvi Sinha Dhillon. COVID has emphasized like never before the need for quality healthcare in India. Medical awareness has increased. Preventive health testing has increased. Overall, the demand for quality healthcare has increased. While government spending on healthcare is 1.35% of GDP, expansion is visible in private sector healthcare. There's ongoing capacity expansion in newer geographies and focus markets to cater to the rising demand for healthcare in India. Max Hospitals is a case in point, and so we're very pleased to welcome today Abhay Soi, Chairman and Managing Director of Max Healthcare. Abhay, thanks very much for joining us on NDTV. Great to have you on Serious Business.
Pleasure is entirely mine.
Congratulations on your most recent quarterly performance. But we're looking at the big picture first. And I made some broad assertions in my introduction. But from where you're sitting, which is a vantage point, how are you seeing the healthcare space grow, mature, evolve in India?
So I think the healthcare space in India has really come of age on multiple counts. If you actually see, COVID has really created an awareness of healthcare, an awareness of what sort of facilities were there. The seriousness for healthcare has made people purchase private insurance. The percolation of insurance has been massive over the last couple of years. And that's really provided an impetus to private healthcare in India. When we look at global medical tourism, that again is a massive sort of opportunity for the Indian healthcare space besides India. What we are seeing is the competitive advantage that India enjoys as far as medical tourism is concerned, both on basis of skill sets as well as the price we do it for, which is perhaps the lowest in the world. Coupled with the fact that manpower, I think we've got skilled, the demographic dividends are really working on our behalf with respect to, you've got 60% of the population, which is very young, looking for employment, and you've got nurses, doctors, we're the largest producers of nurses, doctors and medical technicians in the world, the largest exporters, whilst everywhere else in the world there's a massive shortage. I mean, NHS today has a shortage of about 60,000 nurses. You're seeing massive supply issues as far as skilled manpower is concerned in the United States. Whilst in India, we don't have any of those problems. So I think, the efficiencies in healthcare have played out, and a lot of these things have played out for the healthcare sector in India.
You've set me off in many directions, but I'm going to actually start with the manpower piece first. Skilled doctors, nurses, sure, currently India is a sort of source for them, indeed, for geographies like the United Kingdom. But they've got to keep pace with the growing explosion in demand for healthcare facilities in India. Looking forward a bit, not here and now, 5, 10, 15 years down the road, is there enough being done to sort of develop an adequate pipeline of such professionals?
So I think first and foremost, the government is actually doing a lot as far as skill development is concerned in India. They're encouraging programs such as Heal in India and Heal by India, in which new nursing colleges are being set up, setting up of medical colleges being encouraged. And you've seen that in the public space, you've seen announcements towards that in the public space. So all of that is going to help us harness the energy of all the youth that we have in India who are seeking employment. So I don't see a shortage, at least in the next decade or so. But perhaps, as the population ages into the future, yes, those could be challenges if they're not addressed at this point of time.
Okay, so let's talk about Max Healthcare, because it's been a challenging and rewarding sort of chapter for you. I'm going to start first with how the integration has been. Touch upon that briefly. The review of systems that were already in place, but really elaborate on some of the optimization pieces that you have particularly brought into the equation.
Well, Max Healthcare, when we did the acquisition and the subsequent merger, was already a best-in-class performer as far as a lot of things are concerned. They had a geographical concentration in the Delhi NCR market. The largest players in the National Capital Region were perhaps the highest occupancy, the best doctors, the best contribution margins. But I think thereafter it sort of lost its way a little bit. At least that was my outside-in perspective at that point of time. So those were indirect cost items and so on and so forth, and we worked on those. We were able to within a period of when we did the acquisition, we took a check of about $500 million from KKR, and we levered the company up. We borrowed a lot of money. There was about 2,300 crores of debt in the company, which is about 8 times our profitability, which is very, very high. But we were quite aware of the fact that the margins they were operating at were significantly lower than what we were doing in the same market. And we had given ourselves about 2 years to get that right. And we said, look, we are operating at a 20% margin, they're operating at 8% margin. So in the next 2 years, and we put in all anxieties, apprehensions in place, and we said, look, in 2 years, we're going to raise their margins from 8% to about 20%. Well, we were able to do it in 10 months, actually. And then I remember by the 24th of March 2020, and we had entered the company in June 2019. By 24th of March, we were already hitting about 19% margins. So, we were sitting, we were very this thing. And then COVID struck. And there was this massive you're aware at that point of time, there was, everything was shut down. And we were still sitting on 2,300, 2,400 crores of debt. The operations had improved at that point of time. Through a lot of details, and it's about inches, it's not about the major things that we did. There were a lot of small aspects that we looked at.
Give me 2 examples of the inches that make a difference when you're looking to streamline and optimize operations like a hospital healthcare chain.
So, right from the nursing, which was linked to installed capacity, we believed that it should be to occupied capacity in various wards. So, that is something we tinkered around with. From something as large as that, so that's really your manpower deployment across various wards and ICUs and so on. There's no need to have it for installed capacity. It's dynamic and you can move with the, so that gives you some leeway, right down to a particular credit card company which used to enjoy 10% discounts. For people when they came to hospitals, and that was leading to something I remember as small as 1.5 crores of discounts that we used to give. Now, nobody in my mind chooses a hospital based on a credit card discount, but that's the situation it was in. So those are, literally there were 220 line items. Okay. And, in our first presentation, it's probably still on our website, when this is October 2019, we had called this. We said, look, these are 220 line items and these are 240 crores of cost savings at a time when the entire EBITDA of the company was 240 crores. So we were looking to double that, and we'll do that in the 20 months, which I mentioned. And then March 24th of March happened and shut down. And that was another series of challenges which has started.
And we're going to talk about that, but I want to now turn our attention to the here and now as far as Max Healthcare is concerned. You've talked in recent interviews about expansion plans being on track, potential for, adding to existing facilities, the brownfield approach, the build rather than buy. And I'm going to have a couple of questions on that approach. But here and now, what do you have chalked out for Max Healthcare?
So we're already operating at very high capacity utilizations of about 76 to 78, 79%, depending on the quarter. Healthcare is the seasonal business. The first quarter is a low quarter and the fourth quarter is, high occupancy quarter and so on. So and this is midnight occupancy. What that means is during the day, we have about 120% occupancy in some of our hospitals. These spaces are crying out for, our doctors require more infrastructure over there. There are other doctors who want to join, but we have no OT time to give them. We have no beds for their patients, and so it's becoming challenging. We've had to move out our offices from these hospitals, move into nearby malls. What we're doing is elevating a business need, actually. What we are doing is doing brownfields. creating hospital facilities or towers adjacent to existing hospitals to tap into our already sort of existing demand. So that's the first phase, and we are building about 2,900 beds on a base of 3,400 beds that we have, and we are doing this over the next 3 years. So we're constructing, about 600 beds in Mumbai. No new hospitals being, commissioned in Mumbai in the last 20 years. We are commissioning about close to 1,200 beds in Delhi NCR, places like Patparganj, in Saket, in Gurgaon. We are building out in Mohali. So these are all adjacent to existing hospitals. Thereafter, I think one of the benefits of having the kind of margins that we've been able to sort of ilk out over the last few years has been that we have the cash flows to redeploy more. At present, we are sitting on huge amounts of free cash flows, which we're looking to deploy. So we're looking at other cities as well.
New cities.
New cities. So,
and just a flavor of how you zero in on some of these new cities.
So what we've done is, we're not pioneers, really. And I keep saying this, we like to do things which others have done, but do it better. We've actually chalked out a list of 21 cities where at least 2 or 3 of our competitors or peers have already proven viability. We intend to do it better like we do at present in perhaps every micro market that we operate in. So there are about 21 cities. These are places right from Patna to Lucknow to Kanpur, Bhubaneswar, Pune. There's a list of cities that we have. And these are places where we're looking to build out or acquire.
And then, if we talk about the new cities, that's not factored into the 2,900 extra beds, which is coming on stream in the next 3 years, because that's capacity addition in sort of existing locations, right?
Absolutely.
I just wanted to clarify that.
Absolutely.
In these new cities, is there the inorganic option still on the table? Because there's so much anticipation of activity in private healthcare right now in India, sitting here in the middle of 2023, or are you going to just build it yourself?
No, so there's always that dichotomy, build versus buy sort of. The first preference is to buy, but you must get quality assets at the right price, and we are very conscious about ROCEs. So it should be the right asset. It should be a place where we can put our board. Of course, there could be improvements we can do subsequently, but the infrastructure, the location should be good enough for us to sort of put our brand there. And I think the second aspect is really that it should be at the right price. And when either of these two things are not possible, then we look at building out in those places. But obviously, I think acquisitions gives you a faster sort of start.
You've already said quite clearly that, capital for expansion is not a problem, so I'm not going to delve into that in too much detail. Slightly personal turn that I want to take here. What has the healthcare business taught you that all your previous years in turning around businesses in different sectors failed to teach you?
So I think, it's about taking half chances, right? You take half chances and you do your best, and eventually destiny sort of reveals itself. I've always believed that, even in the previous sort of occasions where I've gone into those opportunities, but it somehow got underlined in the healthcare space. Second is, I think, humility and empathy. There's a lot which sort of goes on in hospitals. This is the first time, at least, and this is perhaps one of the only industries in which you're dealing with people and life and death situations, and people when they're very vulnerable. It's not like a typical FMCG or a B2B business or any other B2C business. So I think those are three things that I've sort of
learned from operating in the healthcare space. I wanted to make a disclosure here. We've been in college together, St. Stephen's, different departments of Arthur Anderson as well. And the question I wanted to ask you is, what propelled you to take sort of big leaps of faith, in a sense, healthcare most markedly, but even before that, you've been fairly adventurous with your career?
So Manvi, while you were economics honors in St. Stephen's, I was BA pass. I wasn't a very good student in school. And, I made my way to St. Stephen's BA pass. And at that time, I think it was a little easier to get into college, at least in Delhi University. And thereafter, when I was actually looking for a job, I couldn't get a job. And so I knew somebody who knew somebody whose son was a partner at Arthur Andersen. And I took up an internship, a 3-month internship, because that's the only sort of job I could get, whilst all my other colleagues and friends had full-time jobs. I think at that point of time, I decided to level, or, it probably came upon me somehow that I had to level the playing field. I didn't really have capital or a business to sort of fall back on, and I didn't have, education at that point of time, which would have got me a proper job. So I seized that opportunity, and things changed, things turned. Many years later, I quit my job. I was still doing well, and because I got an opportunity in the restructuring space, and I sort of grabbed that half opportunity, and things changed. When I got into healthcare, post my private equity days, it was a similar sort of situation. I got into a hospital which was a non-performing asset, wasn't doing well. Of course, I had done a lot of homework before this. So where people see me taking chances, there's a lot of sort of, at least in my head, I was very clear that all the line items, the trial balance, all the ducks were in sort of in line. And I wasn't taking so much of a chance. And I did that in 2011. Things changed in 2013, 2014. I think I have been the beneficiary of being a product of my time. There is a huge amount of development agenda which is happening in the country. We as entrepreneurs today are benefiting from that significantly, whether it is the global capital space, whether through private equity or public markets. I mean, today when a businessman from India is sitting across the table of any global private equity fund or public market investors, you have that sort of credibility. There is, people are not looking for negatives. They're looking to back stories coming from India. So I think, I've been a beneficiary, and we were able to do this with KKR putting in 500 million. Of course, they walked off with 2 billion a couple of years later. But that's the opportunity set in India. And when we look at healthcare, if I look at my space today, whether it is the Indian demographics, whether it is the development agenda vis-a-vis education skills and skilling up people in India, medical colleges, the focus on Heal in India, Heal by India, all of this.
All of these are forces that are sort of propelling the sector forward.
Absolutely. And the opportunity set. I think, today the private sector in India, if you look up all the sort of top hospital chains that you're aware of, Apollo has about 10,500 beds. Manipal has about 6,000 to 7,000 beds. Then you've got Narayan Hrudayalaya with another 5,000 to 6,000 beds. You've got Fortis with 4,500 beds. Then you've got Max with 3,500 beds. Then you go into a handful of hospital chains with 2,000 beds. Then a handful of hospital chains with 1,000 beds. And then single hospital. Add it all up, it's not even 75,000 beds for the whole country in the private sector. I mean, really, healthcare in India has been provided by large government hospitals and very small sort of nursing homes which are, sprinkled across the country, smaller towns, smaller cities, etc. And I think, since COVID, there's been a coming of age as far as the Indian private healthcare sector is concerned. Because, I did suspect that prior to that, there was a little bit of a trust deficit, with the private healthcare space that is expensive and, you can be taken for a ride and so on and so forth. But I think during COVID, when
the faith got reaffirmed.
We got reaffirmed and people were sitting in their homes, I think watching TV while the world was mothballed and protecting themselves. You had private healthcare space, shoulder with shoulder with the government, people coming to work while, and nurses coming to work, ambulance drivers coming to work, doctors coming to work, the managers coming to work, and they could, each one of them had a potential of taking the infection back home. And these are not people who signed up for the army.
Right. And yet they came.
Yet they came. And
through and through.
Through and through. So I think, that got reaffirmed. And again, like I said earlier, the awareness, the percolation of insurance, just the general per capita income increasing, the middle class sort of rising, the demographic divisions that we have, it was a great place to be in today.
And it's now time for frequently asked questions, questions that are derived from comments of NDTV viewers and subscribers online. So Abhay, these are going to be very straightforward, simple questions. There is a perception out there that private healthcare providers charge more. What's your defense?
So I think first and foremost, private healthcare providers charge. Government hospitals where it is free don't charge. It doesn't mean it doesn't cost at government hospitals. It's just that somebody else is paying. It's sort of subsidized through grants, which is not the case in private healthcare. Secondly, you have to keep in mind the cheapest healthcare in the world today, and significantly cheaper, okay, is in India. And the third aspect is, look, you have very large listed hospital companies now. A lot of companies are listed. And every year in the quarterly results or in the investor results, we all speak about price hikes, which usually happens on the 1st of April. And you wouldn't have seen a single situation where price hikes which have been declared have been more than 2 to 2.5% impact on revenues because of price hikes. So it's not a significant increase. What we try to do is usually we have 33%, 34% of our total cost structure is indirect costs, which usually increases by about 6.25% every year. The employee cost, we've got 25,000 employees. And when I say 25,000 employees, includes about 12,000 nurses at $300 a month. They earn 23,000 rupees a month, which is the lowest in the world. I mean, at the end of the year, you have to increase their salaries. The salaries on average increase by about 7%. All other costs increase by about 4.5% to 5%. Baked in, everything increases by about 6.25% every year. We need to set this off. Right? We set this off by taking a price increase. Do keep in mind, if I look at my total occupancy in a hospital, 10% of our beds are totally free for the poor.
Yes.
35% of our capacity caters to ex-servicemen, central government health scheme employees, public sector undertakings, and so on and so forth. These rates have not been revised for the last 9 years. Presently, the government is revising these. Okay, some revisions have happened in the last month and some more are expected shortly. So that has been flat. Other than that, you've got insurance, which is, and everybody else who comes into the hospital, half of them are insurance patients and half of them are self-pay. Now, the burden sort of in some measure comes to them, but eventually the impact on revenue is only 2.5%.
Okay,
that's
point
the
taken.
increase.
There is also a perception, and this is again reflected in some of the comments, that when you walk into a private hospital, perhaps you will be asked to do more tests, perhaps avoidable procedures, or if I can rephrase, more is asked of you rather than less. How do you defend that?
So look, if you look at a private sector hospital, and let's say you've got, like I said, 25,000 employees, there are about, let's say, a few hundred people in management, in finance, etc. You've got about 4,000 odd doctors. When you go to a hospital, you're meeting a doctor. A doctor does not get a share of the bill in no private hospital. They get money for surgical procedures or they get money for their visits. No hospital would provide inducement to a doctor. It's not legal, it's not moral, and no private sector hospital would be able to do that and get away with it.
So you're basically saying that there is no motivation for doctors to prescribe more.
Absolutely.
They are prescribing what is required.
Well, what they think is required.
Okay, those are just two, but frequent questions, and I think we've addressed them adequately here on Serious Business. Abhay Soi, thank you so much for your time, for joining us on NDTV, for charting the growth for private healthcare generally and for Max Healthcare in particular. Good to have you.
Thank you so much.